This lecture is on gynecologic emergencies. I have no disclosures. The objectives are to discuss the sonographic features of and pitfalls in diagnosing ovarian torsion, discuss sonographic features of pelvic inflammatory disease, and list the sonographic features of hemorrhagic cysts and endometriomas. Now, to get started, here are 4 challenge cases, and these cases will be covered during these next 30 minutes, and I invite you to look at these cases and try to decide on their diagnoses. Let's start with torsion. There are many nonspecific findings with torsion, but the most common cited in the literature is ovarian enlargement. It is important that diagnosis is made as quickly as possible as salvage rate drops over time. And one thing I hope to convince you by the end of this talk is that Doppler is unreliable, both for viability assessment or for diagnosing torsion. Now here we have an ER patient with pelvic pain. Notice the asymmetric size between the 2 ovaries. The right ovary is enlarged, it's increased in echogenicity, and the follicles are pushed over to the periphery. Color Doppler failed to reveal any vascularity, so did spectral Doppler. This is a sagittal view through the uterus. Here we have the cervix, the uterus, and we see that the ovary is displaced into the cul-de-sac. This is a patient with ovarian torsion, and which finding do you believe is the most important? Well, in this case, and in many cases, it is displacement of the ovary into the cul-de-sac, or can sometimes be seen above or superior to the uterus. Here's a patient also presenting with right pelvic pain. We have comparison views of the ovaries. You see there's a discrepant size between the ovaries. We don't have as much detail because this was done transabdominally. The patient could not get a transvaginal exam. And from this study, we see that there is an arterial tracing provided to demonstrate flow in the ovary. Now, if you look closely, it's very hard to tell whether this tracing was obtained from within or around the ovary. This was a patient with ovarian torsion, and the best clue is the asymmetric size enlargement of the affected right ovary. Here's a 13-year-old who presented with acute pelvic pain. You can see here the left ovary is enlarged due to the presence of a hemorrhagic cyst. The color Doppler failed to disclose any vascularity in this ovary. It's unclear whether this is because the ovarian parenchyma is compressed by this large cyst or whether there is lack of flow. Here's a comparison between the 2 ovaries. You see the difference in appearance and size between the left and right ovary. Now, when spectral Doppler was performed, arterial flow was demonstrated in the left ovary. And here's a comparison with the right ovary. Now, because there was arterial flow, even though it was asymmetric, it was felt to be related to compression by this hemorrhagic cyst, and the diagnosis of no torsion was given. Now, in re-review, you can see this is a long or sagittal view of the uterus, and again, the ovary is placed in the cul-de-sac. This is the enlarged ovary with a hemorrhagic cyst, and in the operating room, this ovary was torsed. So again, the position of the ovary was the important factor in determining that it was torsed. So even when you don't have much detail, such as in these images, you can see that the ovary is enlarged in relation to the uterus. This right ovary is found behind the uterus. On this sagittal view of the uterus here, we can see that the ovary is displaced behind the uterus into the cul-de-sac. But what is also useful is comparison with old studies where you see that the right ovary, at a time when the patient was pregnant, is located in the right ovarian fossa. And now you can see that when it was torsed, it was displaced into the cul-de-sac. Now, how about this case? We have patient presenting with right pelvic pain. We see asymmetric size between the right and left ovary, The right ovary is enlarged. There's echogenic stroma within the right ovary, perhaps due to hemorrhage. The follicles are displaced and compressed. And we see that there is arterial flow in the right ovary. And although the flow is asymmetric, there is arterial flow. Is this right ovary torsed? Well, the pathology on this was torsion, and it's just to show that the presence of arterial flow does not exclude the diagnosis of torsion. How about venous flow? Well, here's a patient presenting with left pelvic pain. Again, we have a comparison between the left and the right ovary. The right ovary is normal in size and appearance. The left ovary is enlarged. It may be displaced. It's hard to tell due to the enlarged hemorrhagic cyst or hemorrhage within the left ovary. Now, in this case, venous flow was found in the left ovary, but this is a case of ovarian torsion, again demonstrating that the absence or presence of arterial and venous flow is not as reliable in making the diagnosis. Now, this 26-year-old presented with left pelvic pain. Again, we have a comparison between the right and the left ovary. We see the left ovary is more echogenic, it is enlarged, there's hemorrhage within the ovary, the follicles are pushed to the periphery. There is high resistance arterial flow in this left ovary. You can compare it with the flow or the pattern of flow in the right ovary. There was also venous flow detected in this left ovary. And since the patient's pain was improving, the patient was sent home with the instruction to return if the pain should return. So at the time it was felt that the patient may have torsed their ovary, but it was currently detorsed. The patient again feels acute pelvic pain and returns to the emergency room. Again, we see size discrepancy between the ovaries. The left ovary is enlarged and echogenic. Follicles are displaced to the periphery. But this time, the spectral Doppler shows improvement in arterial flow to the left ovary. Again, it was felt that perhaps the patient had a large hemorrhagic cyst in the ovary, which was now retracting, accounting for the improved flow, and the patient was sent home. Once again, the patient felt acute pain in the middle of the night, returned to the emergency department, but in this case, we again see the enlarged ovary, but an absence of flow on the color Doppler examination. This patient went to the operating room, and at this point, the ovary had necrosed. So this illustrates the importance of making the diagnosis early, as the salvage rates decrease over time.